Hello.
Yes,
So,
ma'am.
how was it? Any issues with any concern that you guys are facing? Any confusion? Any questions? Any doubts? None? You should have doubts. No one has a doubt. I am a little disappointed.
Left side it's there, but right side
What?
for this week. Left side there is, I feel fat pad is
No,
there,
I'm
but
not
right.
talking about this picture. I am saying what all we studied yesterday. Anyone has any doubts, any confusion? Anything that was difficult and you could not understand? Or were you all able to understand everything that I taught? That's a good thing though. Anyone?
Some point I'm not able to like differentiate between tear trough and under eye hollowness.
That's okay because tear trough is just the beginning of under eye hollowness. So whenever the under eye hollowness begins, it begins from the medial side. So the initial part where the hollowness starts, that part is known as tear trough, and then it can extend beyond to cover the entire eye. So whenever the under eye hollowness is just initial, it is known as tear trough.
Okay.
Anything else? Any other questions? Okay. So should we proceed ahead? Would someone want to revise the concerns that we did yesterday? Can anyone name it? One each. Can you all tell me what all concerns we learned yesterday?
Forehead wrinkle,
Forehead wrinkles,
glabellar lines,
glabular lines,
butterflies, growth, under eye fat pad,
under eye
tear
hollowness, under
trough,
eye
crow's
fat
feet,
pad, crow's feet, under eye roll. Anything else? Okay. And what about the protocols for rejuvenation? What all did we study in that?
rejuvenation,
The protocols:
parameters,
symmetry,
symmetry,
golden ratio,
OG's curve,
OG's curve, and rule of third. Right. Okay. So should we go ahead with the next concern?
yes, ma'am.
Okay. So our next concern is the nasolabial fold or the laugh lines as they call it. So nasolabial fold are these folds which, can you all hear me?
Yes, ma'am.
So nasolabial fold are these folds which you see around the, starting from the ala of the nose and crossing the corner of the mouth, right? So as I told you, when aging happens, everything goes downwards, inwards and medially, because of which these folds become more and more prominent. Okay, it's a sign of aging. So whenever you have nasolabial fold, your treatment is going to be taking it upward, backward and laterally. Okay, putting everything. So all this cheek volume, all this volume has come down. Our aim is to take it back, right? So our aim is to take all the volume which has gone down here and place it back to where it belongs. So this should be the highest point. Cheek, as I told you, cheek is one of the prominent, the zygomatic eminence is one of the prominent poles of the face. Okay, and this should be the highest point, right, where all the fat belongs. So you have to take it back and put it up whenever we have a nasolabial fold. Okay, how we are going to do that we will discuss when we learn the procedures, but I hope you all can clearly see
Yes, ma'am.
that all this thing which is creating a fold here has to go up, right? Clear? So these are all the fat compartments. Again, you all can see that all this complete thing comes down and gathers here. Okay, so this is the ligament which is holding it. That's why it's not able to cross this line, right? Because it gets holded here. So everything deposits here, right? With me, everyone? Now, this has an impact in dentistry as well, because this puts extra pressure on your dentures. All this muscle pull, the pressure coming from all this tissue which gathers over here, puts extra pressure on the musculature in this area, leading to the falling of the denture, right? So when you take it back and rest it on its position, it even helps with the dentures and bridges, etc. that you all give. Okay, now one important aspect to understand in this is, lot of people, what they do is, lot of people who are into cosmetology, what they do is that when a patient comes and they say, now they don't see that it has aged from here. What they see is they have lines here. Okay, they are going to come and tell you that, you know what, I have laugh lines here. That is the concern which patient will come with. Now I have seen a lot of people filling this with filler, trying to mask it with filler, but that is going to make it even worse. Why? Because you are adding more volume here. It's like there is a poly bag which is filled with a cotton and you add a stone in it. It's going to go more down. Okay, it's not going to come up, right, with weight. So you are adding weight here, which is not a solution. Plus, it's going to make it look more worse. It's going to make the area look more heavy over the period of time. So the first thing to do in such cases is lifting. And you have to guide the patient accordingly. See, this is helping. They will come and tell you, you know, why don't you fill the filler in these lines? So you have to tell them, this is not the solution. Lifting this is the solution. Okay, that is your job. For that, you should be clear about it. Right? Now, the extended concern is the depressive smile. The smile going down, sad smile. Okay? Now, this happens because of a muscle which is known as depressor anguli oris. DAO. The muscle is somewhat like this. It's somewhat like this at the corner of the mouth. And the action is, the origin is here, the insertion is here, to it pulls the corner of the mouth down. Okay? Now, if the corner of the mouth is only a little bit down, like the first image, like this image, can you see the difference between the two images? In the first image, there is only a little bit of sadness, a little bit of smile going down. Whereas in the second image, it's more. The blackness is coming till this part. The darkness, can you see the darkness at the corner of the mouth? That is coming till here. Whereas it's just till here in the first picture. Okay, that means that only this part of the muscle is more hyperactive. Whereas in this picture, the hyperactivity is at this level, because it's pulling the corner even further down. So when a patient comes to you with a sad smile, you have to evaluate three things. First, that if the sadness, the extent of the drooping. Okay? The second thing that you have to evaluate is also there's one more difference in these two pictures. I'm so sorry for this. There's is one more difference in these two pictures. Can someone tell me what is the difference? One more difference in the two pictures. The sadness of the smile. Can someone tell me? Anyone? Apart from that, in one patient the smile is less sad, and then the second patient the smile is more sad. What else is the difference?
Corners of the lips are more inside.
Okay, that is one thing. What else? What else? Volume loss. In the second patient, you will see that there is too much of volume loss at the corners. There is almost no volume at the corners. So in such patient, Botox alone will not work. You will have to do volume replacement in these areas. Okay? So when a patient comes to you with a depressive smile, you have to check two things. First of all, where the pull is originating from. Okay? And second, you have to see if there is a volume loss. If there is a volume loss, you need to replace it with fillers as well and do the Botox, both the things together, right? So you need to do a thorough evaluation of the patient, right? Now this is one case. So all the time, most of the time the cases for depressing smile would be very easy to understand. Patient would come with a concern where you will be able to see the smile going down, you know, the curvature of the smile becoming ulta, or you will see volume loss. Yes, and Ishita, you want to ask anything? Okay. So you will see either of the two things. Now this is one case. In the first picture, now the concern of the patient was that everyone says, why are you always sad? So in both the patient she is smiling. Both the cases before and after she is smiling. But her concern was, everyone tells me, why do you always look sad? Now you can see there is not much volume loss. You can also see that her smile corners are also not going down. Okay, but then also her smile looks sad. So you might get such tricky cases as well. Now I'll talk about this picture ahead, and you guys have to tell me what was the origin of the smile being sad. Okay?
And thickness of the upper lip was less.
That should not make the smile sad. A lot of patients will come with thin lips. We'll come to know. We'll work on this. We'll discuss this. I have full pictures ahead where full face is visible. We'll talk about this. Okay. So next concern is, again, this is also known as laugh lines. So laugh lines can be anywhere. It could be upper, lower, anywhere. Corner of the mouth. Okay. So these are also, people call it laugh line as well. The technical term is marionette lines. Okay. These are static lines. So these lines are even visible when the patient is at rest. They are not giving any expressions. You will mostly see around the corner of the mouth anywhere. Okay, what are these lines? How does it happen? Anyone? Anyone? No one? Please tell me, someone guess at least. These lines here. This.
Auricularis muscle.
What about it?
It's circular in nature. Over time, its volume loss.
Muscle volume loss? Muscle ki hyperactivity is there.
Hyperactivity.
But I said that this happens at rest as well. Hyperactivity will happen when the activity is happening and instead of activity the muscle is hyperacting. Okay, these lines happen because of two reasons. One, because of the pressure coming from top. Okay, from here. And second, because of the volume loss. As I said, bed king size, bedsheet king size, it is tightly tucked in. But bedsheet king size and bed has become queen size, the bedsheet is going to look crumbled. Same is the case here. Okay, it's the bedsheet which is looking crumbled, over the bed, right? So 2 line of treatment. Again, first you will have to make it tighter, and second, wherever the volume loss is there, you will have to replace the volume, but never adding the volume before tightening it. Okay? Jaws. These are jaws. This. Can you all see? Now what are jaws? Jaws is all the fat compartment, all this fat compartment this fat compartment, because I told you it goes downwards, medially and inwards. So it's also going downwards, right? It's going like this and it's going like this. Whatever is here comes here and whatever is here goes down. So all this fat goes down and gets accumulated here. Here. So this also needs lifting. Okay? Pre-jaw sulcus. This is a pre-jaw sulcus. Just before the jaw, because of that bulge, there is a shadow which falls ahead of it. So never try and fill that shadow. The sulcus, the fake sulcus that has been created. Okay? You can't just fill it up. The ideal thing is to lift it, and the sulcus itself will go away. Okay? So this is pre-jaw sulcus. With me, anyone has any doubt till now? Okay, next, malar fistules. Has anyone seen this? These. Okay, so you will see that mostly patient will come and say that, this usually happens when I have not had enough sleep, or that I have taken alcohol or something like that. Then this area around the cheek will start looking puffy. Okay? So malar fistules, usually they are not always present. They would come and go. Sometimes they would be more prominent, sometimes they would be less prominent. Okay, so this would be the concern, that sometimes it looks too much, sometimes it becomes flatter, sometimes whenever I am like I have not had good sleep or I have had alcohol, it puffs more, there is more puffiness. That would be the concern of the patient. Can anyone tell me the cause of malar fistule? Anyone? Ishita, you're not audible clearly. Write down, drop a message in the chat here. I can't hear you. Anyone can tell me? Anyone else? Are you guys there? Patient having what? Patient having kidney issues. Okay.
Fat deposits.
Fat deposits, kidney issues. Anything else? Anything that you guys can think of? My mom gets
Maybe
it.
due to herniation of fat from this ocular region.
Herniation of fat. Okay, your mom had this issue when she had kidney issue. Okay. What else?
Hyperlipidemia.
Hyperlipidemia. What else? Okay, I'll tell you. This is water retention. Now, why does it happen? It is not going to happen in all the patient with kidney issues. Okay, that is one thing, that there is edema and then the body fluid accumulates here and there. But why here? The reason being that the layers of the tissue here creates, there is a false pocket creation in the tissue layer, because of which there is a bogey pocket which is created, and then there is water retention in it. Okay, so that is the reason why the water deposit happens here. The pumping action is not better. So how will you solve this? What do you think? How can you solve? A pocket is created, how will you solve it? What has to be done there so that the pocket gets closed? What should be done? Don't tell me exact procedure, but tell me, ऐसा क्या होगा कि pocket will close? Anyone? Okay. Whenever there is a wound and sutures are given, what exactly happens? What exactly happens when sutures are given? What is the mechanism of healing? The wound gets closed, right? How? I hope you guys are there. Please turn on your screen so that I can see you all. It's as if I'm talking to a blank screen. So I would request you all to be able to, so that I can see you all. Please tell me that when we give sutures, how does a wound close? What happens? What is the mechanism? Pathophysiology.
There is a migration of cells from either side of the wound edge
And
towards
next
the base,
step?
and there is after a few days fibroblasts start to
And then what
form in this
happens?
area. Then the new vascularization and all the tissue formation, then overlying it skin, like all the
Okay,
cells
so
form.
basically when the fibroblast comes, there is fibrosis. I mean collagen formation. Collagen is laid down, right? Which will stitch it and close it. So what we need here is we need collagen. So once the collagen formation will increase in this area, the layers which have separated from each other will become tighter. So we'll have to do something which will help in the formation of collagen. Okay?
Mesotherapy.
Okay. Why mesotherapy?
Helps in the activation of fibroblast and
Okay.
formation of.
Very slow procedure though. It will take months with the level of mesotherapy. We can create a controlled wound. Very good. Now how will we create a controlled wound? Because we know whenever there is a wound, there are fibroblasts, and fibroblasts will come, the collagen synthesis will happen. So we are going to create that wound with the help of fractional CO2 laser. Okay? So the treatment for this is fractional CO2 sessions. We will discuss more about it when we read fractional CO2. But right now you have to understand the concern and how we are going to treat it. Okay? Now this is also a inflammatory condition, rhinophyma. The nose becomes big, swollen. Inflammatory condition, so you will have to again do two things in this. One is you will have to give steroidal injections to reduce the inflammation, and then on top of it you will have to do fractional CO2 to smoothen it out. Okay, we will discuss more in the treatment planning part. Just understand the concern for now. Okay? Spider veins. Now what are spider veins? All of you will see it on face, you will see it hands, legs, multiple places. How does it happen? How are spider veins formed? Can't hear you, Rakhi. Anyone?
Breakage of capillaries.
Breakage and blockage of capillaries, the end capillaries. Okay? So because there is breakage and blockage of end capillaries, so the blood gets retained over there, it dries up over there, and it gives a pigmented appearance. So your point your treatment should be aimed at removing these small blood clots and blood pigmentations. So what we'll have to do is pigment reduction laser. Okay, that will break the pigment, the old pigment which is lying down over there, the decayed pigment which is lying down, it will break the pigment, and ultimately the pigment will be phagocytosed by the body cells. Okay? Okay. Moving on to scars. So now you guys have to answer what is the difference between a normal scar, a hypertrophic scar and a keloid scar. You guys need to know, when you look at a scar, you will have to understand what kind of scar it is, because based on the scar, the treatment is going to change. Okay? So what all do you know about scars? Please tell me. Anyone? Dr. Akanksha?
Hypertrophic scar.
Yes.
Ma'am, this should be the hypertrophic scar that is present at the site of injury and it generally regresses. Whereas a keloid, it is present, it may extend beyond the site of injury and it usually does not regress.
Okay. Any other
Ma'am,
difference?
keloid scars, the people have tendency to
Yes.
occur it again and again. In keloid scars, no one can repair it. Will try to repair with suturing and all, it will extend more. While the hypertrophic scars, if we try to repair or do the primary closure, with time the scar goes away.
Right.
While the keloid never goes.
Right. So there are three different kinds of scars. One is a normal scar, the small ones you get after injury or after the sutures have been done, you will see a fine scar. That is a normal scar. Hypertrophic scar is a scar which is a little bigger than normal. Okay, it looks a little big, elevated, right? But it will always be within the confine of the injury line. It will never spread to the normal tissue. Wherever the injury line and healing has happened, the scar will just look bigger, but it will be well confined within the line. Once you have done the treatment of a hypertrophic scar, there are no chances of recurrence. It will be healed nicely. The healing would be good. Whereas when it comes to keloid scar, it extends beyond the margin of the scar line. So it will look bigger, elevated, unshaped. It can extend anywhere in any direction. Second, keloid has a genetic tendency. So if in your family, your mother, father or grandfather, parents had a keloid tendency, there are chances that you might also get it. Second, it has a chances of recurrence as well. For example, you have got an injury, you have got a keloid. Once it is treated, once the scar revision has been done, chances are a keloid might come back again in that place. Also, if you have one keloid in the body, chances are if you get any other injury anywhere, there would be more chance of formation of keloid there as well. Okay, so that's about keloid. Now how the treatment changes. Now these are all elevated scars that we are talking about, which are elevated beyond the margin of the normal tissue. So when it's a normal scar, you are going to do sandpapering over it. Like how whenever there is a roughness on a surface, we sandpaper it, right? To make it smooth. How the sandpapering is done? It's done with the help of fractional CO2 laser. We will learn about the mechanism and how it works and everything later. But the basic concept is, when the scar is elevated, all you have to do is smoothen it out and bring it to the normal surface level. And if the scar is pigmented, you will have to reduce the pigmentation of the scar with pigment reduction laser. Okay? If the scar is a keloid scar, the treatment changes. Number one, you will have to shrink the scar. But you can only touch a keloid scar if it it has been stable in the same position for more than 6 months, because keloid has a tendency of growing day by day. So if a patient has got an injury, healing has happened, keloid has formed, and patient comes and tell you, you know, I got an injury 3 months back, you cannot touch that scar. You'll have to wait. I mean, when the patient says, like, if he has come after 9 months and you ask him that, is your size increasing, then and he says that, you know, it was increasing for few months, but then 3 months back it stopped increasing. So you need to wait for 3 more months. The keloid should be stable for at least 6 months. Then only you can touch it. So first what you will have to do is you will have to shrink the size of keloid. How you will do it? With the help of steroidal injections. Once you have shrinked it and got it to a level where it's more close to the normal skin surface, then it's the matter of correcting the color, the texture of this area. That you will do it with fractional CO2 and pigment reduction laser. Okay? You should opt less for scar revisions with keloid scar. They're very tricky. Okay? Fine. If the scar is a hypertrophic scar, maybe you can do a scar revision so that you remove this hypertrophy and the fibrosis near it, give a fine line, properly sutured, and then do fractional CO2 over it. Or you can give kinocort injection, reduce it even further if the patient is not willing for surgery or if surgery is not needed, and then do fractional CO2 over it. So based on the size, position, patient's willingness, you will decide and take a call on what the treatment should be. If it's a normal scar, you can very well treat it with a fractional CO2 laser. Now comes the depressed scars. The scars in which the line is below the surface of normal skin. Okay? Like if this is the normal skin, the scar is like this, which is below, dipped in. So you cannot, if the scar surface is below, you cannot do fractional. It will not penetrate till the base of the scar. Okay? So what you will have to do is you will have to bring the scar up. You will have to bring the scar up. How will you do it? You will do it either with scar revision or with a technique which is known as subcision. Subcision and filler. No, mesotherapy won't help much, Ishita, in this case. So you will have to do subcision and filler. Now what is subcision? Suppose this is a skin, okay, this is top part, this is a bottom layer. So these are multiple layers of the skin, right? And you have a scar which looks something like this. Okay? So what you do is, you take a needle, tuberculin syringe 19 gauge. I'll tell you about this, I'll show you this. We'll do patient about this, okay? So you will take a needle and you will put it like this inside. And you will go like this. So you will go below the scar. Okay, and you will, sorry. So this is what the scar is like. Okay. So you will go below the scar here and you will break these fibers. Okay. You will break the fibers. So you will go below the scar, you will break the fibers. It's like how it happens when a tube is punctured, a tire is punctured. You have to fill the air in, right? You have to fill the air in so that it gets more and more lifted. In the similar way, first of all, you are creating a space in between because there is a lot of fibrosis here. There is a lot of fibrosis, right? Below the scar, there is always fibrosis which has pulled it below from the skin surface. So you are creating an injury. You are creating space between the top layer and between the bottom layer below it. Now, once you have created a space, you need to fill something in. You have to stuff something so that it becomes more and more lifted. So you will stuff filler, dermal fillers inside. Just a second, guys. Yes. Okay, someone is joining. Dr. Anil had joined, but I think he left again. Okay. So what you do is you have to stuff something in between so that the top layer gets more and more lifted. So you are going to stuff dermal filler in it. Once you have stuffed dermal filler, you have created a gap between the top layer and a bottom layer. Now why stuffing is needed is because you have freshly created an injury. If you don't stuff anything, the layer is again going to stick to one another. Just because the layer doesn't stick to one another, you have to create some stuffing. And the scar will become at least 30-40% better. Now once the scar is lifted to the surface, now your fractional CO2 will penetrate the scar better. So then you will do fractional CO2 over it. Got it? Any confusion, anyone?
What is subcision?
Subcision is a technique where we are putting a needle here inside below the scar and breaking the fibers. That technique is known as subcision.
Okay.
Okay? We are going to see this for acne scars. Now acne scars are also depressed scars, right? Acne scars are different from acne marks. Scars are where pitted scars are there after the acne has healed. The pits in the skin, little larger than open pores. That's acne scar. Okay? Got it? Any confusion, anyone? Okay. Next is nevus. Now can anyone tell me how is a nevus different from a mole? What is the difference between nevus or mole? Nevus is elevated. Mole is not. Mole is attached. Okay. Anything else? Anyone? Have you all heard the term nevus and mole? Okay. Nevus is the medical term, mole is the layman term. Both are same. So don't get confused. They can be of multiple types. There is an entire chapter on the classification of nevus. Okay? It can be elevated, it can be pedunculated, it can be sessile, it can be attached, it can be on top of the skin, it can be under the skin, anywhere. Based on the position, they are categorized. They can be green colored, black colored, brown colored, skin colored, anything. Okay? Nevus, mole, everything is same. Right? So based on the surface of the mole, based on the position of the mole on the face, you will take a call as to how it has to be treated. Okay? Now there is one speciality that you have to understand about nevus, is that it's mostly circular or oval in shape. You will never find a nevus which is like this on top. Sorry, let me change the color. Which is like this on top and has a flat base. Okay? If there is a top, there is going to be a base for it. Now it depends if it is like this, if it is like this, if it is like this, or it's completely out like this. It depends. You will get to see. When you see a mole, you will be able to understand how much of the circle is outside. Okay? Now see, for example, this one is mostly from the top, it looks like this, right? That means it has maybe this much of base or this much of base which is inside as well. Okay? Now this one. This is mostly like this, flatter, right? On the top, on the skin. So that means it might be having a flatter base as well. Got it? It is going to be oval or circular. Now this, for example, is mostly outside. It's mostly like this, right? So it's going to be having only a small base inside. This again, flat, very flat. So it will have a little bit of flatness inside. Got it? So your treatment will depend on each and every nevus. The treatment would be different. This you may remove by cautery. This will go by pigment reduction laser. You will have to just remove the pigment with pigment reduction laser. For this you might need an excision, or you might have to remove this with surgically. Okay, maybe the treatment would be something like this, where you will give a cut, you will remove this suture, you will remove this nevus, and you will give 1 or 2 sutures over here. So never ever think कि मैं इतना कट कर लेती हूँ कॉटरी लेके, because what will happen, right now it's looking this much from the top, only this part is bothering the patient. If you try and remove, maybe this patch will look like this, which will become a little bigger because the base is bigger. Okay, so not always the standard treatment is cautery removal, cautery cutting. It will really depend. If you only see that the entire bolus, the entire bulb is out, then only you take a chance of removing with the cautery, right? So the treatment for each and every nevus is very, very different. Okay, they are very tricky to treat. Moving on, next is nevus of ota. Anyone has seen a patient with pigmentation around the face, around the eye, around the cheek, big, bold, dark pigmentation? It's called as nevus of ota. It can be present at birth. It can appear few months or few years after the birth. Okay, but it's a dark, maybe blue, black, brownish pigmentation that you will see. Okay, mostly the treatment is pigment reduction laser, but because it's a very stubborn pigment, you will have to tell the patient that I'll have to give you at least 3 to 4 sittings to start seeing the results. And after 3 to 4 sittings, if I feel that there is a fainting of a pigmentation even a little bit, there is a scope that it will go down eventually with multiple sittings. But even after 3 to 4 sittings, if there is no result, then that means that pigment cannot be removed. Okay? Right? Freckles. Freckles are more common in white skin, Caucasian crowd. You will see lot of melanin pigmentation around the malar area, around the nose, most commonly. Again, the treatment of freckles can be peels and laser. It's the melanin sprinkle over the face. So you'll have to do pigment reduction laser or pigment reduction peels. Okay? Skin tags. Now what are skin tags? Where does it happen? Anyone? Any idea? Any idea?
For some people with insulin resistance, diabetes,
Diabetes, insulin
excessive
resistance. What else? Where does it
excessive
occur?
cellular growth on the neck area, hospital.
Why? Why are they more common in the neck area? Why? It happens on the neck, it happens on the back of the neck, it also happens in the underarm area, in the thigh area. Why all these areas are more common?
Due to the fats, or when they folds in the skin, particularly in that area.
Folds and friction from the clothes. In the area where the skin is rubbing against the cloth. Okay? And because Diabetes or any other thing, when the patient is hefty, there are a lot of skin folds which are formed. Also, it happens when someone is wearing chains etc. in the neck. Because of rubbing of the skin with those chains, the tags are formed. Okay. Now again, it has a familial and genetic tendency. So if someone has a tendency in family, they are more prone to tag formation. Second thing, even once you remove it, there is no guarantee they can come back again. They can be of skin color, they can be pigmented. Okay. So once a patient comes for tag removal, you will have to do cautery. You will have to hold each and every tag and cut it one by one with a cautery. Okay. And you have to tell the patient that there are chances of recurrence again, so that they should not come and tell you after a few months that I paid for it and it has come back again, because there are chances. You have to inform the patient beforehand. Right?
Ma'am, can they resolve without treating?
No, mostly doesn't resolve. Mostly it does not. You have to remove it, or else the patient get used to it. I have seen so many patients carrying so many tags for years, because it's harmless, it's not painful or anything, it's just there. Okay, so it doesn't really bother. So sometimes patients are used to it. Now this is different. What is a what? This is different from a tag. Anyone? Anyone? What is a what? It looks like this on the skin surface. Cauliflower like. Rough. Pedunculated. What is a what?
HPV infection.
It's a sign of HPV infection. Okay, it's a viral infection ka manifestation, clinical manifestation. So whenever a person comes with a wart, first of all, don't touch it with your bare finger, because it can transfer to you. You have to ask the patient also not to touch it with their finger, because they can have it in finger also. Okay, it's contagious. Right? And there are two things that you will have to do. First, you will have to ask the patient to visit a physician, MD medicine, or someone, whosoever is family physician, whatever is, to tell them, so that they can get themselves treated for HPV. Okay. Now there are two things again in this. Either it can happen when the patient has active HPV, so they can be actively having that infection in their body. Sometimes even when the infection has gone, like few months back or something, the wart remains. Sometimes the wart goes on its own once the infection subsides. So you have to ask the patient that since how much of time you are having this wart. If the patient says, I have this since past 8 to 10 days, then you don't treat it. You ask the patient to visit the doctor, get themselves treated for HPV, take antiviral medicines, etc. After taking medicine, sometimes it heals on its own. And you have to tell the patient that after you have completed your course of antiviral medicine, wait for few days. If it doesn't go even after 1 or 2 months, then you remove it with cautery. Okay? So sometimes it will go on its own, sometimes it will not go. If it has not gone after few months of HPV also, then you can remove it. Right? Any confusion? So please differentiate it from tags. Tags and warts are very different, don't get confused. And be very careful when treating the patient. Okay. The next concern. Xanthelisma. Can you see this? Yellow color deposit, this. This is xanthelisma. What is xanthelisma? Can anyone tell me? It would be mostly yellow orangish in color. Anyone? No one? Okay.
Cholesterol deposits.
It's a cholesterol deposit. So whenever this is present, it's a sign of something wrong with the body cholesterol level. Okay? So you have to ask the patient to get their cholesterol checked. Right? Again, same thing. Sometimes when the cholesterol level has come to normal, this might disappear. Sometimes when the cholesterol level comes to normal, even then this will be there. So in that case, when the cholesterol has gone down to normal, but xanthelisma still is persistent, you can remove it either with cautery or pigment or fractional laser or peels, TCA peels. Okay? And there are chances of recurrence again. So that also you have to inform to the patient that there are chances that it can come back again. Okay? Right? So this is xanthelisma. Next, melia. Small white elevated. Now xanthelisma is present around the eye mostly. Okay, you will always see it around the eye. Now melia is also present around the eye, but it is most common in the lower side of the eye. It happens in upper area also, but most common in the lower area. Now melia is also, they are small elevated, white elevated thing, bigger than whiteheads, much bigger than whiteheads. You will see white balls, small balls. Okay? How does it happen? Anyone? Anyone? Any idea? It's the keratin deposit. So the corneous layer, the stratum corneum, makes more keratin. And because the patient, either their skin is very rough or their skin has a lot of open pores, which entraps that keratin. So it forms a keratin plug, like small keratin balls, which gets encircled in the tissue, and it gives the appearance. It is called as melia. So what would be the treatment? First, you remove all the melias. How you will remove it? Like you remove the mucocele. Okay, you remove it like you remove a mucocele. How? You will puncture it from one part with a needle, a very fine needle. You will puncture the base. Like if this is the melia, it's going to be like a ball. So you will puncture it from here. You will dig in, little you will dig in, you will open, you will make the hole bigger, and you will press, so it will pop out. The ball will pop out. Okay? This is how you treat melia. So you make an opening, you make the opening a little bigger with the needle, and then you press it, like how you pop a pimple or you pop a blackhead. Like that, you press it with your 2 fingers. When you have enough opening, the bigger opening, the ball will pop out. Okay? And then you give the patient some tea-bagged or soframycin ointment for a day or so, and it will heal. Once it has been healed, you have to tell the patient to do lot of scrubbing for their face and lot of hydrofacials, etc., so that the tendency, their skin becomes more and more smoother, and the tendency for future melia formation reduces, because again this has a chance for recurrence. Right? Any doubts? Okay, so we'll move on to next, comedonal acne. The smallest form of acne. It can be skin color, it can be a white head, and it can be a black head. All the 3 things comes under comedonal acne. Okay, which are little bumpiness of the skin. Okay, so the treatment would include thorough cleansing, which will happen with hydrofacials, medifacial. You have to prep the patient's skin. You have to make sure the skin is cleansed nicely, multiple sittings. And then you have to do peels, etc. for them so that their skin becomes better and better. If at all it's in the forehead, etc., which could also be because of dandruff, then you have to guide the patient accordingly also for the lifestyle management. Okay, this all we will learn when we learn about acne more. Okay, in the treatment part. But right now you should be able to identify the concern. That is our main aim right now. Okay. Active acne. Everyone knows about this. It will look red, pink, poppy, pus filled, non-pus filled. It can be single, it can be multiple. We all know how to identify an acne, right? Acne scars. Once the acne has been healed, okay, now suppose a person had an acne here, like this was an acne. So when it was supposed to be healed, it was supposed to be healed like this, but instead it heals like this. Why? Because there is a lot of fibrosis here which is pulling the base down. It is causing the base to stick here. So if you try to do laser over this, it will not penetrate till the base. There would not be healing and filling of that gap. So what you need to do is, as I told you, whenever there is an acne scar, you need to do subcision so that you release this fibrosis. Then you need to do the filler inside it. And once it has elevated a little bit, after subcision and filler, the scar will become 30-40% better. Then you let it be like that for few days, you let the entire healing happen, and then you do either lasers or peels over it. Okay, to make it more smoother. Okay. Now acne marks. Acne marks are different from acne scars. Patient don't know. They will come with a scar and they will tell you, I have an acne mark or I have active acne. But active acne are different, acne marks are different, and acne scars are different, and the treatment are different. So acne marks are the pigmentations which remains even when the pimple goes away. Okay? Why does it happen? It happens because during the healing period, when the wound was raw, there was sun damage. Any pigmentation on the face is because of sun damage. Okay, because when the skin is in healing phase or the skin is raw, there is sun exposure and it has caused to the pigmentation. Okay, so what you need to do is you need to give peels or home care to the patient to reduce this pigmented marks. Okay, so you don't have to do any subcision fillers, lasers, etc. Laser will also work, pigment reduction laser, but you don't need to go for subcision and filler. Now sun damage can be of multiple types. It can cover the entire face. It can make the face, if the skin is lighter, it can make the face look a little reddish. If the skin is darker, it is going to make the look of face little brown, tanned, black, etc. It can happen on cheeks, forehead, around the corner. It can be anywhere. Okay, so the treatment depends on, like, there are multiple treatments for it. We do peels, we do mesotherapy, we do meso cocktails, we do medifacials, we do lasers. We are going to discuss all of this when we learn about the treatment, right? Next is melasma. Now what is melasma? Anyone? Anyone? Most common in Indians. You will see a lot of patients bhar ke for melasma. What is it? Melasma is a specific type of pigmentation. It's a kind of pigmentation which happens, yes, it's common during pregnancy, but it happens first, females, most commonly in females. Second, it happens most commonly in the cheek areas. So it usually begins with, so there are stages of melasma. If you come across a patient who has a melasma on the cheek, little bit here, it's the beginning of the melasma. If it has increased and gone towards the nose, or it has gone below, or it has gone here around the eyes and towards the forehead, that means it's progressing. So it is going to be more difficult to treat a melasma which has progressed if something which has just begun is easy to treat. Third, it has a genetic predisposition, genetic and hereditary tendency. So if someone has melasma, the chances are you are more prone to melasma. Fourth, it is a sun damage, but it is aggravated by certain factors, which includes hormones, lifestyle, not using sunscreen, applying too many cosmetic products. All these things makes the skin more and more weak, and on top of it, when the sun damage happens, the melasma is there. Fifth, melasma can only be controlled. It cannot be completely removed. And control means you can control it to zero it down, but it will come back again if you leave your precautions. Like how a person has hypertension, what you have to do is you have to bring it down to control, right? When someone has diabetes, you will have to bring it down to control, but once they lose that control and take sweets, again the sugar is going to rise. Same is with melasma. So you have to tell the patient, even if I do best of peels, even if I give you best of home care and the melasma goes, but the moment you stop applying sunscreen, it is going to come back 10 times stronger. Okay? Right? And never ever go for any kind of steroidal creams or treatment for melasma. It is going to severely cause a rebound. Always go in a subtle way, in a progressive way. We are going to discuss in depth about melasma and its treatment, but you need to identify it first. Okay? Okay. Spasm, hemifacial spasm. Which side is normal?
Left side is normal.
Okay.
Right side.
This is right, this is left. Now tell me, which is normal?
Left is
Right.
normal.
Left is normal. What is happening?
Left.
What is happening?
Normal facial expressions are there, and on the right side, the expressions are not normal.
Okay, Chamandeep, this is not hemifacial palsy. This is hemifacial spasm. You are talking about palsy.
Okay.
So, spasm means the muscles are going into spasm. Okay? So, muscles are going into spasm more so on the left side. They are
Left side.
contracting more, pulling the entire face towards the left. So, right side is normal and left side is going into spasm. This is very confusing with another condition, which is facial palsy. Now, suppose if this was a patient of facial palsy, which side is normal?
Left side.
Left side
Left
is
side
normal. Okay, left side is normal. Why? Because the expressions are there on the left side, whereas right side is not able to draw expressions because it is paralyzed. Okay, so you will have to check thoroughly whether it's spasmodic or it's a palsy. You will have to take patient's history. You will have to ask for any history of trauma or any surgery or something which has led to palsy. Also, whenever it's a hemifacial spasm, it is going to be in bouts. It's not going to be always there. There are timing when the face will be normal and there would be timing when it's contracting more. Okay? So there would be periods of normalcy as well. Whereas when it's a palsy, the face is always going to look like that. So if it's a spasm, the treatment would be giving Botox injection wherever the muscles are involved, whichever muscles are involved in the spasm. That would be the treatment. Whereas if it's palsy, this side is normal. So your only treatment what remains is making this side as much normal as possible. So you will do more of the lifting procedure so that you can at least bring back some symmetry when the patient is at rest. Okay, so these are a little complicated cases. Once you learn all about Botox, fillers and thread, you will be able to manage such cases better. But first you need to identify them, okay? The point here is to understand the identification. Now this is a case of blepharospasm. Blepharospasm is the spasm, the contraction where you will see the patient blinking their eye again and again, okay? And in the advanced stages, they would be barely able to keep their eye open because there is so much of spasm of the muscles around the eye. It's usually bilateral. So whenever there also, initial cases of hemifacial spasm may look like blepharospasm because it starts mostly with eye. So there would be contraction of the eye. But in hemifacial spasm, it would be unilateral. Whereas in blepharospasm, it is always going to be bilateral. Okay? Right? So that's about all the facial cosmetic concerns, guys. What you guys need to do is I'm going to send you the list of concern that we studied today. If you guys have any doubt, please feel free to ask me today on message or maybe tomorrow's session. Yes, Akansha, you have some doubt?
Ma'am, is it possible to get this PPT?
Yes, definitely. I'll share this PPT.
Thank you.
Okay? And what you guys need to do is, you guys, in fact, what the notes you are going to get now post course, you are going to get this PPT in that. Okay? Next thing, what you guys need to do is, you guys need to send me 3 pictures of each concern so that it's well seated in your mind. Okay? And if there are any doubts, ask me tomorrow. So in tomorrow's session, what we are going to do is, I'm going to teach you facelifts, which includes facelifts with the help of HIFU, and it includes facelift with the help of threads. Also, I'm going to teach you chin lipolysis. So these are the 3 things that we are going to learn tomorrow. Then 2 things would be remaining, which is Botox and fillers. I'm going to teach you personally when we meet, because there are a lot of injection points that you need to learn when doing Botox. And it's very important that you practically learn it in front of me. You all are going to get workbooks where everything is, all the drawings and everything is given. So you can write, you can make your notes, etc. You can write down, you can mark down all the points which will be helpful in your practice also. So we will be covering facelifts and deoxycholic injections tomorrow. And rest of the things we are going to do as we start with the patients. Before that, your session would be there. Like for example, when we are going to do Botox filler patient, before that we will do Botox and fillers, and then we get into the patient section. Similarly, before the lasers, I am going to tell you all about lasers, and then we go into the laser section, and same with the peels, etc. Okay? So that is how it will go. So all the best to you all till then, and do share the concerns like today. Remaining concerns, it can get a little complicated because there are too many things, but I'm sure once you go through it again and again, the pictures, it will sit better and better in your mind. Okay? See you then. Good night, everyone.
Good night.
Right now.
Good night.